So thank everybody for joining. We have some people here from the Precision OS team, Tanya Romanek, who's our Chief Product Officer. We have Christine McJanet, who's here from our partner engagement team, and John Bracken, who's our Chief Operating Officer. And I'm going to take a minute to introduce Dr. Jarvis-Selinger in just a minute. But this Impact Consortium is being put together to help drive as mentioned, a technology-enabled education front. How do we optimize resident education in 2025? So the agenda for today will be some introductions. Uh, Dr. Jarvis-Selinger will go over some educational challenges. We'll get into some opportunities. We'll share a prototype of what we're planning to do. And there'll be a discussion next steps on this consortium roadmap. So before I share the next slide, it's really, for me, it's an honor and a privilege to introduce Dr. Sandra Jarvis-Selinger. Just to give you some background, and some of you may know her, she's a developmental psychologist with a PhD in human learning development and instruction. She is a professor in the UBC Faculty of Pharmaceutical Sciences and an academic strategy consultant in the UBC Department of Orthopedics. She served for the past 10 years as academic associate dean in the Faculty of Pharmaceutical Sciences. Prior to that, she held leadership roles in the Faculty of Medicine as assistant dean, faculty development, and a director of curriculum, where she led the renewal of the medical doctoral program and advanced faculty development across undergraduate and postgraduate medical education. In addition to this, Dr. Jarvis-Selinger has contributed to educational leadership internationally through all the societies that we know in orthopedics, including the AAOS, the OTA, the AOA, and the IPOS. And her research is really focused on some of the biggest challenges and addressing those, which include educational innovation, professional identity, formation, and knowledge translation, health education. So with that, Dr. Jarvis-Selinger, I'll pass to you, and I'll pass over the remote to you as well.
Thanks very much, Danny, and thanks for the introduction, and welcome everybody. So I don't see my control. Oh, there we go. Oh, I'm not controlling the slides.
Okay, I can advance them.
Okay.
So as Dr. Jarvis-Selinger sort of gets ready to give her part of the presentation, I think one of the reasons we're all here, and certainly something that I've sort of dedicated my career to, is to reduce medical complications and improve patient care in every community and country around the world. And we know that the only way to achieve this is through high quality, accessible education. Dr. Jarvis-Selinger, over to you.
All right. So one of the things that we really wanted to start out with this afternoon, this evening, is really thinking about some of the educational challenges that residency programs and health professions education face. And we've sort of put them in a couple of categories, but the thing to really think about is that it's not just one thing, it's really that confluence of many different things that are coming together that always create where are the opportunities to really think about resident education. So if you hit the first one. So we know that, over time, over months, over years, over decades, there's this increasing procedural knowledge. It's always expanding. And the challenge is that the educational initiatives really need to keep up with that, keep current with it, and understand that in a lot of situations, you're really having to do more teaching with the same or less amount of time. Next one. You all probably have had experiences with the idea that residents may not encounter the same spectrum of cases, and that can create some real inconsistency in their training. So that variability, which is naturally occurring where the residents train, really can create an educational challenge for residency programs. Next one. You all live with the idea that the increased financial pressures really limit the time and resources available for teaching. And there's always that balance between patient care and resident education. And so the idea of reduced reimbursement and the other financial pressures really means that some things end up having to move to the side. And occasionally that is time for resident education with those that are supervising and stewarding that educational opportunity. Next one. It's been quite a few years since we think about duty hour restrictions, and that obviously reduce the total time residents can spend in clinical settings. But the other part of the limited clinical hours for residents is really that idea that patients aren't staying in hospital as long as they used to, meaning that residents have shorter exposure to cases. And so if you think about this idea that historically, if you had patients in hospital a bit longer, you had more opportunities for the residents to be able to interact with that. And so it's not only the resident clinical hours that have caps on it, but it's also how much time they have with different cases in hospital. Next one. So there's always this readiness expectation that continues to change. And the idea is that, you know, the pressure on the system with all of these other things coming together is that residents are expected to achieve higher levels of independence earlier. And so it's that idea that things start to really speed up in that learning environment with all of the things like expanding procedural knowledge and the idea of limited clinical hours. And so that pressure on surgical residents really puts a lot of pressure on the residency programs. Next one. The other thing that we really look at is how orthopedic surgeons really have to prioritize time in the OR for efficiency and patient flow and turnover and all of those kinds of things. And so those external pressures with the healthcare system for optimizing OR time also means that it might impact and create less flexibility for teaching. So less time and more need really does affect the resident education experience. And the challenge with that is that the pressure to optimize OR time has really changed. And so the other thing is the rise of the ambulatory surgical centers and the shift to these models really mean, again, that you have shorter patient encounter in these centers. There's a lot of efficiency pressures. You may see more of the simpler cases. And so while it creates efficiency in the healthcare system, it can really directly impact resident education. And the last one, if you go to that one, is with all of this, there is an increasing need for the objective assessments to really be able to move residents along that learning continuum. And so there is this constant chase for programs to find reliable ways to measure skills and progress and how to do that in a standardized and validated way. And so really it's meant to say that there's a constellation of pressures that start to really come along with this, with understanding how resident education continues to change now and in the future. So with all of that, really what this initiative, Impact Initiative Consortium really looks at is how can we create support mechanisms for orthopedic programs in being able to address and tackle these key educational challenges through technology-enabled education and collaborative technological innovation. And the purpose of this evening, and we will obviously leave time for lots of questions and discussion, is really to be able to create these partnerships in a consortium model to enhance resident training, improve learning outcomes, and really lean into building user-led and user feedback solutions to understand that everything in the educational environment needs to be maximized. So how do we think about maximizing faculty contribution? How do we think about maximizing technology-enabled education? And how do we do that in a way to support resident education, which goes back to what Danny mentioned in terms of the vision about really improving patient care through an educational lens.
Thank you, Sandra. So I'll give an example of traditional resident case preparation. So as a resident, this would apply to me, and any of the surgeons in the audience certainly could attest to the experience that they'll have faced when a resident prepares in the current model, which is before a case, we'll watch videos of a surgical procedure, we'll read about the case or read around the case with multiple resources, and I may even do some multiple choice questions that may be relevant to the case. And what this sets up for the faculty is a little bit of lack of clarity, because the questions that then the faculty would ask me, or now I would ask a resident, is, well, what did you read? Have you done this before? What did you want to try and learn during this case? Do you have any experience of doing this procedure in the past, or when was the last time you did it? And how many cases have you done that are similar to what we're about to do today? This is sort of the scrub sink conversation that we may have. And what that creates is the following. From my perspective as a faculty, the educational plan going into the OR is frankly unknown. There's a big question mark around that. And that generates a set of emotions for both the faculty as well as the resident. My emotions as a faculty is I'm a little bit in the dark. I have been and will continue to be somewhat uncomfortable because I don't know what the resident is capable of or not capable of. So I have a level of uncertainty. On the resident side, our feedback would suggest that they certainly have a lot of stress in this experience and environment. They also feel uneasy and they're lacking confidence. And what they want to achieve from the OR is also very uncertain. So if we think about that in the context of KSB and the requirement to be evaluated, 80 cases per year, 320 over the course of 5, so they could sit for their American board exam, it doesn't actually create a very rich environment that's clear for both the learner or the mentor. Now, I want to share this prototype, and this is just something we're working on, and we can talk about some of the feedback. But the way we think that this may work moving forward is if a resident had access to a series of videos online that were curated regarding each case, and I'll play this video in just a minute, then they would go to the virtual operating room using virtual reality where they're being evaluated of certain skills that they're doing. And after that, they would get feedback that they could share with their attending that they're about to operate on the morning of or the night before. Press play. So they would watch a video and they would go into the OR, and now they're in the virtual OR. And if I was practicing a femoral neck fracture, while I'm doing this in VR, I would be evaluated on multiple parameters. And the power of virtual reality is that we can collect multiple data points and then compare them to what would be standard. So in this case, a femoral neck fracture, I'm being compared and then to standard, and then I get that data accessible on an iPhone through an application which I could share with my attending. And what does that generate in a scenario where that same resident did that type of preparation? They used a technology to test and practice spatial skills being how to put a wire into a bone, for example, while using intraoperative C-arm. They made and recognized their mistakes. And what this does is it generates actionable data, and they can repeat it until they have mastered that particular procedure. What that then creates is a really powerful ecosystem for the faculty, because if I'm the faculty, I can now see that this resident has done 10 cases, that they've used the C-arm 25 times. I also see from their data that their guide pin might have been a little bit low on the femoral head. And what this creates is a very rich and clear learning opportunity for both the resident and the attending. So the educational plan that I may propose to the resident in this scenario is let's practice that exact skill of you putting that guide wire in the femoral head that was sort of unclear in your practice. And the emotion that I would feel is I'm very guided now. I have clarity and structure about what I'm going to teach, and it's efficient. And as Sandra mentioned earlier, given the lack of time that the residents have and the lack of time that we have in the operating room, structured and efficient education in the OR is paramount importance to help residents achieve the goals that we want to. I'm also comfortable with the resident now that I've seen what they can and can't do, and I'm actually much more trusting in this environment. And for the resident, they're much more confident. They, in fact, themselves feel very organized and also very secure that they're going to be practicing the thing that they want to, and that learning objective will be achieved. So I think the opportunity, really what this presents is, if I was to summarize it, is clarity for both the learners and the educators through technology and performance data to achieve that optimal surgical experience, not just for the faculty, but also for the mentor, or pardon me, for the student learner. And Sandra, I'll pass to you on this part here.
Yeah, so if you just want to back up one,
Sure.
Danny, for a second, I think the other thing is really to hit home the point that in the example that Danny provided for resident number one, a lot of that background to figure out where the opportunity is for teaching and learning in the OR comes from self-report. Right. And so in those cases, when you have that faculty approach, those questions are really meant to say, what do you think about this? What's your perspective? And then as a faculty member, you're trying to infer something from how many cases they've done, what the self-report they've had about any experience, if you don't have that directly from having worked with them before. But that really leads to some inefficient opportunities potentially, because then as they start in the OR with you or they're attending, there really has to be a lot of time spent thinking about, is that true, right? So that you're starting, as Danny has in here, from that level of uncertainty of really trying to see what they've said from their perspective. Really bears itself out in the OR. When you think about scenario resident number two, it's that idea that the data and the feedback that are being provided to the faculty for them to create that efficient opportunity in the OR, and start to think about what are the opportunities that that particular resident might need in order to transfer the skills that they've learned in the technology-enabled environment into the practice environment, really comes through from data and comes through from that objective feedback. Now, there's still the opportunity to sort of moderate as you see them use that information to apply it into a real-world setting, but it really gives you a different place to begin to start and to use that background data, as Danny said, to be a lot more efficient and comfortable in these applied areas. So what we want to do now is pause for a minute and give you an opportunity to ask questions, to think and give feedback about ideas on the situation of an impact consortium and in this space of technology-enabled education. So the first thing is, are there any questions in anything that we've presented or any clarity that you'd like to get from us?
So this is Brent Faber. My question is, how can we easily do this? I think that everybody that's online is supportive of the VR philosophy. How do we flip it to the level of going through the KSB? Yeah, the surgery part has been played with other platforms. I think all of us online, I think, feel that the VR will help and is better. The knowledge is, with the AI is perfect in grabbing other entities. And then on top of that, the behavioral thing is an interesting model. So just, what's the way to flip the switch? Can completely agree. Just don't know, where's the transition, where's the tipping point that moves this thing forward?
So I can start with that. So great question, Brent, and thank you for that. So the knowledge piece, through the OID, I think that's the sort of assessment that the ABOS would like. How we're setting up the skills aspect is when you're in the OR, after the OR, if a resident asks for an assessment, there's 11 questions you have to ask, or there's 11 questions you are being asked about the resident from preoperative planning to postoperative planning. Our plan, our tentative plan there is we're going to be making 11 separate videos using VR on each of those 11 components for the resident to view before the operating room. And within each of those videos, the resident will have a chance to go into the virtual reality environment to generate data that they will then be able to share with you before the OR. So that allows them to basically plan for that procedure under the umbrellas of all those 11 segments that they're going to be evaluated on and actually put this into fruition. So now we're actually connecting the preoperative plan directly to the surgical plan, directly to their assessment through that intervention. And I want to ask Sandra to comment on the behavioral aspect, which I think you'll also be evaluated on or asked to be evaluated on. And Sandra has some thoughts on that.
Thanks for that. So I think that obviously the heavy place to lean into the behavioral components of the KSB are when you are seeing residents in practice. But one of the things that we're interested in really exploring is that the residents that are really in that VR technology-enabled environment also have data that's coming out of that in terms of the motivation and sticking with it and being able to move through the different way a curriculum plan might be laid out in your program. And so that starts to give you some signals about the behavior, being able to take on some independent self-reflective learning, being able to use that in a way, as we used in the example, to use that data and feedback to really go back in and see where they are, where they know what they're doing, where they may be struggling with things. And so the whole point is then, how does that become a bit of a precursor for you to be able to understand the behavioral side of KSB when you're seeing the resident really be self-directed and starting to move that kind of professionalism piece forward? And then how does that then apply in say, the professional behavior in the OR?
Well, I think that it's a change in culture and change in history, because we haven't gotten there yet, where this is the way we've done it over the time as residents have learned in cadavers, residents done here, and we're starting to push forward with VR. And the more that we can make it cookie cutter, I think it's the easier for the, it's easier to get it done. I know it's difficult. We have good and bad days at Kettering. Things make sense. Then, you have senior members that are like, well, this is the way I learned. So it's a generational and a cultural change. So, with KSB being pushed forward, however we can incorporate it all together. I mean, to me, the knowledge is in this day and age is easy, to the point of you can find knowledge anywhere across the net and across anything. The VR part and the behavioral is really where this would be an interesting way to push it forward. So that's what I'm looking for and working forward. But if it is a change for attending physicians and faculty who are used to Gestalt, and Gestalt isn't the greatest, and VR is different. So the more cookie cutter you can make it, the easier it is, but that may not be a way that we can do it. I mean, that may not work. So.
Sandra, did you want to comment on, I think Brent brings up a really good term, Gestalt and Spidey sense. Can you share your thoughts on that? And then there's a question from Arian after that.
Yeah, absolutely, Brent. I absolutely agree with you. I have been calling it the spidey senses of surgeons for their trainees. But I think you make a really good point. So if you take anything, knowledge, skills, behavior, and you think about it over the trajectory of a resident coming into your program, a lot of times the very early residents become a lot easier because there's a defined, structured skill set. They're really starting out. It's easy to then observe those sorts of things. And so what ends up happening is we have a lot of objective assessments early on, right? So knot tying and handedness and dexterity and all of those kinds of things that happen. But as you think about the resident really going along in their developmental trajectory, as they become more competent and they begin to incorporate internally those skill sets that they're trying to learn in the knowledge, skills, and behaviors piece, you really want to start to see the whole package come together. And as that whole package comes together, the objective assessments get harder, and the spidey sense, the reliance on spidey senses or the gestalt begins to have to go up. And so that's the balance of saying, really what we want to say is over that entire resident developmental trajectory, that there are ways to really unpack the different parts of how do we interact with a particular resident to create personalized learning opportunities based on data and not just the spidey sense piece. I still think there's a place for it. There's a place for the gestalt. You are all gatekeepers of individuals who come through your programs and go on to graduate and work in the healthcare system. But I think an over-reliance on that is really a detriment to the educational mission.
Agree 100%. That's why we're on. I agree 100% that this is this is where we make some changes. It's going to be slow, but it's the technology is moving forward. So I agree. Thank you.
Absolutely. I guess before Arian jumps in, the only other comment that I will make, because you did say generational, some of the generational issues. Absolutely, we have to understand about those changes. What I really try to get people to think about and reflect on is that it's educational generational changes. So how is education changing over time that then changes the product of that education? And so learners are coming through different educational systems than we went through. And that's making a difference on who they are and how they learn. And so I try to move away from just the kids these days feeling, because that really doesn't give you anything. If you just throw up your hands and say, oh, the kids these days, it's being able to understand that the educational system for the residents who are coming into your program is different than the educational system that we were in. And so how do you react to those changes and understand that all the way along the educational continuum, you are getting a product of an earlier system?
Arian, did you have a question?
Yeah, so the new videos and this sounds really exciting. Is there like a targeted PGY year that these are kind of oriented to, or are they more just a generalized 1 through 5?
It's a good question. We're going to take some feedback on that, I think, over time as to how best to make these videos, because they can get pretty advanced. So when we look at if you look at the ACGME case requirements, we could be as simple from a total knee to a revision knee. So that's something that we're going to test and retest and get a lot of feedback from this group and the consortium. That's where we'd have great sort of back and forth input from you all. How do you see it, Arian? Do you see it across residency years, or do you see it specifically for 1 or 2?
it's hard to get buy-in from more senior residents for anything that's not actual OR or even cadaver lab.
Mhm.
Uh, Cadaver lab they're generally happy with, but anything that's not a physical knife in the hand, it's hard for them. They get excited for it. They like the cool technology aspect of it, but it's hard to convince them that it's a useful tool necessarily that they could actually learn from. We've implemented a basics course at our university, where they are on a rotation for a few weeks, and they are encouraged and forced to use the VR before they do certain things, and it goes in partnership with cadaveric time in our PGY 1 year. So I think, that's where the VR can really take hold, is 1, 2, and 3 years before they've really had a lot of operative experience.
One thing I'll comment on, which I think is probably important, if the residents at that level certainly feel confident and are competent, I think we should consider flipping the switch and making them educators for the more junior residents. And you can use the technology to do that. And in fact, that's a way for you to evaluate in your program to say, if you know it so well, that means you should be able to teach it to a junior resident. And the technology enables that. So that falls under sort of the behavioral aspect that Sandra was talking about on professional identity development. So what are your thoughts on that, Arian, or certainly anybody from the audience?
Yeah, our senior residents already guide through much of the cadaveric time, which is great. Uh, but yeah, it'd be interesting to see how they could incorporate some of the VR stuff into that. Again, it's falling into the hard pressure of time and the duty hour time that all of our residents are kind of facing.
I would be interested in Stephen Kennedy. And also I work with Aaron at the University of Washington. I think buy-in is the hardest. I think that is the biggest challenge, and I think that residents can be very quickly dismissive of a simulation because it's not the real thing. And so I think we're all constantly, trying to fight that, but also listen to what we can do to make it more realistic. And I think for me, the thing that would be most exciting about this would be kind of developing benchmarks of, like, for residents who are meeting expectations in these things at a level 4, that of a graduating resident. And if there are benchmarks within the virtual reality sphere of, you know, this is what, even if it's not perfectly uh, recreating nobody can perfectly recreate the surgical experience, right? Um, but if you can say, like, through the precision score or whatever other score that they could have, you should be able to hit this bar, and they try it and they're like, and oftentimes, even like my experience with the precision system, like for example with the arthroscopy basics portion of it, sometimes people say, oh, it's glitchy. I can't do it. So the system's glitchy, right? And we're like, well, actually, there's good data that this predicts how you can perform in surgery, and it's better than the other simulator. They need to be convinced a little bit of that. And sometimes if a peer kind of says, no, you're not doing it right, or here's what you could do, that I think there is a component of peer teaching, but setting a benchmark of this is the expected score that you should be able to achieve. I think residents do want to be checked off on things. They want to kind of feel like they've gotten some sort of approval of, like, I'm good enough at something, And so I think that would be an exciting offshoot, especially if there was some evidence to show them, like, if you can do this exercise, it predicts that you're going to be able to do this in real life to a certain level with a certain score, certain time, certain accuracy, what have you.
Dr. Kennedy, I completely agree. I mean, we're in the mentality of you have to get this score to get in the residency, you have to do this to pass your board, you have to do this, do that. So having something that's there, I completely agree that they would jump on it more than, hey, this is kind of cool, this is something you could do. Yeah, but I got to get to cadaver. Yeah, I got to get to the OR. Yeah, I got to close. I completely agree with you. I'm gonna, in my junior and hopefully program director in the future, Dr. Steinley is on. And he got a lot of kudos because he worked with the residents. Jared may not respond because he's got 2 kids under the age of 2. But Jared may jump on because he has embraced it despite whatever. Jared, are you available to talk, or you have a bottle in your hand and you have a earpiece?
He
I
doesn't
think
seem.
you've got. Oh, he's there. All right, awesome. Come on, Jared.
Yeah, I'm on.
Oh,
Talk about your experience because the residents love what you did during the first year, or during the July month. I got great feedback, and we haven't talked about it. So
I think
I just be as honest. I mean, because this is something that is generationally changed, and I think you've done a great job. So sorry, I'm throwing you under the bus, but I've done that before.
yeah, this is Jared Steinley. I'm one of the attendings over at Kettering Health Dayton, the residency program. But it's been generally positive. There's a few platforms that are, kind of hit or miss, but I think the general consensus has been the anatomical pathways and platforms have been super helpful. We went through approaches from a trauma standpoint, basically from head to toe, shoulder, elbow. I don't do a lot of the upper extremity stuff, but we did a little bit of wrist, forearm, hip, knee, ankle, and that was paramount as far as going through approaches for, from a junior level standpoint. It was super beneficial for the residents, and honestly, it was helpful for me to, teach from, we never had VR in my training, obviously, but it was nice to go through the applications and software and seeing the anatomy and being able to walk patients through or walk residents through the approaches. I mean, it's pretty good. Like the anatomical approach type things, I think those are like super helpful. Some of the like procedural stuff, like hip nailing, and I think that can probably be worked on a little bit. But from an anatomical perspective, I think the VR stuff is like really helpful. At least from a early residency standpoint, I think the residents got a lot out of it, and honestly, I got a lot out of it as well. So it was pretty cool.
that's great, Jared. Thank you so much for that. Dr. Gugala, you have a question?
Yes, actually, I have a question and a comment. So we've introduced this VR trainings in UTMB. I'm Zibi Gugala. I'm from the Department of Orthopedics at University of Texas Medical Branch in Galveston. So we've introduced a couple of months ago, and we grouped residents, junior with seniors, and we found that actually juniors drives the process and interest among senior residents. Of course, senior residents, they have more OR time under their belt, and they actually find a disconnect. That's find it like a great tool, technical tool, but not necessarily that more like going backwards with what they've already have. But I'm driving a different picture in our department in terms of motivation. I'm using example of navigation and robotic surgery that training navigation and robotics without actually being used in OR was maybe very good educational and then create readiness. But unless it's in OR, it's still some kind of disconnected from the OR reality. So I'm driving a picture that augmented and mixed reality. It will be a future surgery. And this would equip them not necessarily to attain some kind of dexterity and manual skills right now, but also provide some readiness for the future technology that could be in OR. And that also, I found even my colleagues, faculty colleagues, that actually got interest in that because they could face exactly the challenge suddenly in OR. So we could actually drive two missions with this. One is actually truly introduced, juniors and to truly to OR and surgical cases and uses as education tool to realize that maybe in parallel with cadaveric dissections and learning, surgical anatomy, but also as a way of actually preparing them for a mixed and augmented reality that could be a future of orthopedic surgery.
That's a great comment, Dr. Gugala. Thank you. Sandra, do you have any comments on that or Jared's questions, comments?
Yeah, maybe I'll jump in and then Danny, if you want to. So one of the interesting things when you talk about, Dr. Gugala, when you talk about the idea that one potential future thing to contemplate is how technology may be changing the way that you practice. It makes me think of a quote, which is "the media is the message." And so the great opportunity that may be building here is that a little bit of that disconnect comment, which is, if you're in a virtual space, how does that then apply itself to the practice space in the OR? But the virtual space may become part of the practice space. And so then that's another, I think, very interesting thing to contemplate is that when you start thinking about the idea of smart technology really coming into orthopedic practice, into medical practice, into health professions practice, I think that's the other piece to really watch in how that is starting to align with these kinds of practice simulation situations. I think the other thing around the kind of near peer opportunities when you're talking about teaching and learning, one of the things that I always think about is you really, really have to know what you know when you have to teach somebody else about it. And teaching by its very act gives you a lot of insight into maybe what you don't know or what you're not as comfortable with. And so I think that opportunity for those near peer, building and integrating near peer opportunities is also a really great way to think about how residents might be interacting with the technology-enabled education.
Stephen and then Brent.
Yeah, I have like two comments I think that go along with the recent comments from Dr. Gugala and Dr. Steinley. One was when Jared was talking about anatomy course. We implemented an anatomy course this summer also to try to, in similar fashion, go through all the different surgical approaches, and we did pre-work through that so that people could prepare. There was just a lot of questions, a lot of open-ended questions about the anatomy, so that they were looking at pro sections before doing the anatomy. Just using this as an example. And we asked for feedback at the end, and it was, people loved it. It was very popular. But one thing that they said was like, well, the questions, there was too much pre-work with the questions. And I think part of it is like, so this just gets to the concept of like time. Residents are wanting to, they are so, just like the rest of us, we're all kind of limited for time. And they didn't want to be asked a lot of questions of things that they already knew. And so they kind of wanted to, one of the suggestions was as much as possible for us to give them objectives of like what the expectations were and that they could chunk it themselves. So like, for example, some of them like, if you just told me, instead of asking me to demonstrate that I can identify all the carpal bones, for example, just tell me that's one of the objectives. I know that any test that comes up, I already know the carpal bones backwards and forwards, so I don't need to test myself on that. You don't need to prep me for that. Just let me know that that's an expectation, and I'm going to skip over that, and I'm going to work on the things that I don't know. And so that was something very helpful for me for the next time that we do that. And so I think part of what people will, one of the outcomes that could come from this is that is people understanding what are the expectations that will make them successful, even if they don't practice it. So you might create a whole module and for this, and they may look at it and say the expectation for this is that you can do that, and they might say I already know how to do that. I'm going to focus on the other thing to make the best use of my time. So I think time is, we all know that time is important, but I think that's one thing that has a practical application. The other thing I think is the concept of like change leadership and getting buy-in of I think finding some way to generate wins as much as possible. I think the demonstration that Precision OS can actually predict performance in arthroscopy in the operating room is huge. It makes it like real. It makes it, and so like if I was looking at the change leadership for like how to make this big project as successful as possible, like spending some really focused on time on some things that look like they're very achievable and doing them really well and having some data that kind of goes along with it where residents look at it and say, holy, if I do this, I can get better in the operating room rather than trying to get like all the procedures that are covered by KSB, having like even if there were just like three of them where like there was very convincing, evidence that it made a difference from doing the VR to having that would I think that would make a big I think that would have a big impact and it would potentially generate more wins later.
That's great, Steve. Thank you.
Thanks.
Brent, and then John.
Yeah, so one thing, I forget who said it, or maybe Stephen did, is the whole thing about trying to get senior residents to teach junior residents. We've had it for years. There's been no real plan. I just remember this over the years. It's like, well, how do you know that this junior person can do it? And I'm going to hand that off. So they have to take a little bit of responsibility when the faculty and the attending says, all right, you can do this. Well, can I let, Jared do this? How do you know he can do that? And we haven't gotten there because I think it is, what we have done is it's just, we're only up to the third year right now, who have had VR, and that's part of their culture. And I'm hoping in the next couple of years that the senior will go, all right, I'm going to allow you to do this, but I got to collaborate with you for 5 minutes, right? Do you actually know what you're doing? Because if you make me look bad, that faculty is going to not let me do that total. So, and how we get that, I would love to do it tomorrow, and we've sort of talked about it, but I don't know how to push it forward. But that is part of ACGME. They want to have a junior and the senior on services, whether it's PEDS, whether it's hand, whether it's whatever. This is just a way to say, all right, well, yeah, you did that. Now, how do you train or allow the junior to do something? So haven't figured it out yet, but that's how I think we get seniors and juniors together as we move forward. So.
Thank you, Brent. Dr. Fulkerson?
Yeah, I'm pretty new to this, but I've had the opportunity to work with you, Danny, on developing a tibial tubercle transfer technique. But what keeps going through my mind is I think about the corporate videos that are out there from the companies and how slick they make some procedures look. I'm sure all the residents see these. And, trying to synthesize the idea of, somebody who is really used to a certain procedure and has certain tips and tricks, which came to mind when I was actually working with you. There are certain little things that have to be done a very specific way, in my mind, for tibial tubercle transfer to be done correctly. And I think perhaps, and again, I'm new to this, to the extent that it's possible to have the format like that so that the resident feels like they're actually engaged in that sort of corporate slick procedure, and that they are learning something cutting edge, perhaps by working with a person whose name they're familiar with. Um, so they feel like they're getting a little edge, like they're really learning, the best possible way to do this. I'm struck a lot by residents that come into our program. They say, "Oh, that's a really big deal doing that procedure where I was," and now they come into fellowship and they say, "Well, it doesn't have to be that way. It can be really very smooth, very slick." So I'm just sort of talking out loud, but to the extent that you can do that with VR and you can lead the resident or fellow to actually experience doing this in a very smooth, slick, and absolutely correct or optimally correct fashion, I think that will draw them to want to do the VR. It's
I love
just how
what
it
you're,
seems to me.
sorry. I was just gonna say, I love what you're saying about that, John, about the tibial tubercle osteotomy. And I was also thinking, as you were saying it, that about going back to Danny's comment about um, allowing residents to fail. I have certainly learned more from my failures than sometimes some of my successes. And so when you're talking about tibial tubercle osteotomy, that there's some things that you absolutely have to do to achieve success, it would be sort of fun to see them simulate what happens when you don't do those things, in a virtual environment, and see what the repercussions are for the patient. Not necessarily like that it doesn't need to be shown in great detail, but just communicating to them that that would result in this, or the way that you position it could result in that.
That's a great point. I mean, I just quickly comment on that. One thing that just out of the last 2 years, we've come to realize through a few papers that come out that if the distal end of the tibial tubercle transfer osteotomy is too thick, the incidence of fracture goes up significantly. So that osteotomy has to be tapered all the way out to the anterior cortex without leaving a step off. And like you say, I mean, if that could be built in, say, oh, hey, if you make the cut here, we know that this is going to weaken the tibia and your chance of fracture is going to go up. So if you build that into the VR and say, okay, to do it correctly, you have to make the cut this way. Yeah. So yeah,
Sorry to interrupt. I think that's fantastic because there used to be a lecture that would say how not to do AO. How not to do AO was the lectures that came back. So if you almost built in things of, here's how you could get in trouble if you do it wrong. So if you're not doing internal fixation appropriately, not doing AO, it's almost like you said, if you don't do the osteotomy correctly, I mean, it's not going to work. And how that's built into it, I don't know, because right now, to me, VR is built to do everything right. Could there be an algorithm that shifts that over to say, well, if you do it wrong, this is what's going to happen. Because they got to learn what you don't do right. So, sorry to jump in, Dr. Ferguson. Yeah, that's interesting. Very interesting.
Thank you for your comments. We have about 5 minutes left. So Dr. Gugala, you have a question?
Yes, actually, a comment, Dr. Fulkerson, you brought great comment, maybe introducing straightforward but also more challenging cases. This would actually get attention for more senior, less common, and this would actually extend, the users group to include more senior residents. Also, I just want to make a comment. The game changer would be to have haptic feedback. This would be absolutely, you don't realize how much we learn from tactile feedback during surgeries. And that could be absolutely game changer in terms of effectiveness of learning.
Well, we've got about 4 minutes left. Should we talk about next steps, Sandra?
Sure. And I think I want to thank everybody. This is a really great discussion. Sometimes when you saw me put my head down, it was because I was trying to get a lot of notes to say, how do we best wrap this up? I think I will try to do my best in 2 minutes and leave 2 minutes for Danny But I also think we can certainly follow up with a little bit more fulsome summary of everything that was talked about today. So I think, I mean, obviously one of the things coming back to, we really talked about the idea that this really has to be user-led and user feedback, and there's been some really great feedback and conversation in wanting to build this consortium. I think that we have to really ask the question about like how you all want to be involved in this, because I think in order to be able to create the next steps for all the things that you've talked about and your lived experience, that's the kind of interaction and collaboration and communication we're looking for. I will leave the how for another conversation. What I will say very briefly and very high level is some part of the roadmap for me comes into kind of 8 big categories. So I'm gonna say them quickly because the recording will capture them, and we can certainly build it out. And if we're missing things, we can certainly follow up. So I think there's a lot around the idea of benchmarks and really understanding where some of those performance benchmarks could be. I think there was conversation around understanding how to match educational opportunities with the right level of learner. And I know that there was a number of different comments about like what might be appropriate for an early resident versus some resident that's really later in their training. There was conversation, which always is the case in the learning environment, motivation for learning, and sort of that, I think somebody said, the being convinced of wanting to be able to take up those educational opportunities. I think there was some conversation around these near peer teaching opportunities and how that impacts the peer who's doing the teaching and some of the juniors who are benefiting from that, and being able to integrate that as a potential opportunity. Around what I said, the media is the message. So if some of the things within healthcare practice are changing to be much more technology enabled, you really need that level of skill in the technology. I think there were comments around some of this may help residents really understand just the expectation is. I can get into a whole conversation about the hidden curriculum, but when you start to put priorities on things, residents and learners will pick up that that priority means something. And so how do you use these kinds of educational opportunities to set expectations? I think there's something around not trying to do everything in the KSB, but really deciding where are some of the core areas that you can start with in terms of the type of clinical activities that really fit themselves well into this model. And then the last thing I'll say, which is near the end of the conversation, is how do you start to bring more real life practice into the simulation environment? It may be a way that I describe it. We did this more with paper and pen than we did in the VR. But one of the things to do in any kind of simulation is, can you create a make your own adventure based on the actions that a learner is taking? And so that's a really interesting thing to think about, is like the ability to potentially consider pitfalls based on action is always a really great way to get immediate feedback of, you went in the wrong direction and it resulted in this outcome. And so you can back up and try to do that again. So that, off the top of my head, as I was listening to everything, is what came up for me. Danny?
Thank you, Sandra. I'm just going to pass to Tanya for a minute, who's going to talk about next steps from our side, and then we can let everybody have a good evening.
Thanks, Danny. Just in the realizing that we're short on time, Tanya Romanek, I'm the Chief Product Officer at Precision. Some of you know me, some of you don't. For those that don't, it's a pleasure to meet you. But one of the things that we are very conscious of is the fact that you're all incredibly busy. And so we don't want this consortium or this piece of work to be more work for anyone. So what we'd love to be able to do is connect again in a couple of months, probably sometime in early November, and bring that prototype that we have, that we're putting together to that session to get your feedback. This opportunity is for all of us to be able to kind of use these sessions to help create the most clarity for our residents and our attendings so that we can surface that data and create those incredible learning experiences when we have them in the OR. So if you are comfortable with it, that's what we'll do. We'll start putting together some of those prototypes and bring them to you for your thoughts in our next sessions.
Thank you, Tanya. Thank you, Sandra. And thank you, everybody, for joining. We'll look forward to our next meeting of the consortium, and have a great night, everybody.